in your life to speak to our students. Thanks so much.
No, thanks very much, Marianne. Very kind introduction, and it's been an interesting 18 months, and really you and your department, but you in particular, have really led the way and given us so much information and data to work with. It's really been, amazing to behold. So thanks to you, and welcome to this lecture to the MPH students. As Marianne said, my remit today is to really just highlight some of the issues around hospital-acquired infection and antibiotic resistance, and we'll talk, locally and globally. And again, as Marianne says, very, very happy for you to ask questions and interact. I'm definitely not going to be speaking for 2 hours. I hope we can get this done in about 40 minutes and then have a discussion. So let's kick off. So first, it's important to understand what we're talking about when we're discussing hospital-acquired infection, because it is different from the infections that one gets in the community. You'll also sometimes hear the term healthcare associated infection. It's the same thing, although it's a little bit broader. It allows, encompasses different types of healthcare settings, sometimes in clinics and other long-term healthcare facilities. But hospital-acquired infection, or HAI, differentiates from community-acquired by being an infection that begins in hospital after a defined time point, which is arbitrarily taken as 48 hours. And the patient hasn't come in with that illness. So if at 48 hours the patient is found to have a pneumonia and it hasn't twigged yet that that was the cause and they came in with it, that's not a hospital-acquired infection. That's a community-acquired infection, which has just been delayed in its diagnosis. When we talk about hospital-acquired infections, we're really talking about those that start in hospital, the symptoms start in hospital. And also we recognize that some people have been in hospital in the recent past. And again, it's an arbitrary cutoff, but we look at about the last 3 months. If somebody's been in hospital in the last 3 months, they may well have picked up an infection from the hospital. Why is it important? Because there really are specific types of infection that we're looking at when we're talking about hospital-acquired infection. And also because we use more antibiotics in hospitals, we're more likely to have selected out drug-resistant bacterial infections in that hospital setting, and therefore the infections that these people present with are more likely to be drug-resistant. So the first thing to understand about preventing hospital-acquired infection is that there's this sort of pyramid that we conceptualize in infection control, and your major bang for your buck in reducing hospital-acquired infection are all the administrative details, the way that we admit patients, patient flows in hospital, the way we cohort patients. For example, if they're TB, we may have TB wards or TB isolation areas. The SOPs that we use when we identify somebody who could be at risk of a hospital-acquired infection, again, we may isolate them, we may put up signs. All the administrative issues around this really gets the most bang for your buck. The next bang for your buck comes in terms of the sort of breadth of control that you can exert is in the environmental controls. And obviously COVID has taught us yet again, although pre-COVID we had TB to teach us this, how important environmental control is, particularly air changes. So for TB, you're really wanting to affect air changes. So at a district general hospital where there's not a sophisticated air conditioning system, it's all about opening windows and doors and allowing air through and airflow. In a more sophisticated environment, for example, like Hudaskier, where you have suck and pump ventilation systems in the ceilings, you hope that they'll affect air changes and therefore dilute pathogens that are in the air, be that COVID, the SARS-CoV-2 or TB or whatever. Sadly, some of those environmental controls in sophisticated environments don't really work. So when you think they're sucking, they're actually blowing. And we had a case of many years ago where we looked at the airflow from the main drug-resistant TB clinic and found that it was being blown from the waiting area out into the corridor and then into the cardiology clinic because it wasn't going in the right direction. So, but in general, environmental control is important. And then really the personal side of it, you're only really protecting one or a few people is in the personal protective equipment, again, which has been so highlighted during COVID with masks and gloves and aprons, etc. But that really is down to the person and their local environment. That's not giving you a big bang for buck. So this is as I said, the infection control pyramid, and we want to get our administrative and environmental controls just as right as we do personal protective equipment. There are WHO guidelines for core components of IPC, which I point you to for anybody who wants to read more on this subject. In the hospital, we try and alert people to infection risk and the precautions we need to take with the proper signs. So airborne precautions where you need an N95 mask for TB or for pulmonary chickenpox, for example. Or then one would use the red sign outside the isolation area, or if it's in the ward above the bed at least, to ensure that staff are wearing N95 masks. Those people who have bacterial drug-resistant infections that you want to stop transmitting person to person, we use in Churrasquera a blue sign with the contact precautions, again showing people what they need to do. And then for droplet in precautions, for example, for pathogens in the nose like meningococcus, or in patients sometimes where we're trying to protect the patient, not the patient from us, so-called reverse barrier nursing in neutropenic patients, we'll use droplet precautions where we just use a standard surgical mask and hand hygiene. So this is how we try and alert people to the need for using particular precautions. So there are a number of risk factors which play out in increasing risk for hospital-acquired infections. The immune system of the person is important. So you know that at the extremes of age, immunity is suppressed. We have a very high HIV population, cancer patients, transplants, so immunocompromise is a risk factor. Obviously, the longer you're in hospital, prolonged hospital stay, and sometimes that's as a result of what we do to the patients, particularly in hospital-acquired infections, as I'll show you. But the longer you're in hospital, the more likely to pick it up. And then anything which breaches normal surfaces which protect us. So when you breach the skin or the normal urethral conduit of the bladder out, so you're putting in a catheter or you're putting in a tube to help ventilate people, anything like that will increase the ability of bacteria to gain hold in the body where it would normally be protected. When you use broad spectrum antibiotics, unfortunately, you decimate the normal flora of the gut and the skin, and you increase the risk of hospital-acquired infections. And then there's a whole area of administrative issues that we know play into hospital-acquired infections, particularly in the intensive care units. Once you start losing staff in ICU, normally it's a one-to-one nursing, for example. As soon as you lose that, your hospital-acquired infection risk increases in this critically ill patient cohort. When we think about the type of hospital-acquired pathogen, the sort of bacteria that are causing problems, we really focus on the sort of most dangerous ones and most prevalent ones, which are known by the acronym of ESCAPE, which are listed here. So there's a couple of gram-positive bacteria, Staph aureus in particular, Enterococcus faecium, which is a bane of transplant units in particular, but then the main gram-negative pathogens, which are now increasingly important, are Enterobacterales, examples like Klebsiella pneumoniae and Enterobacter species, both of which carry high resistance profiles, and then what we call non-lactose fermenting gram-negatives, Pseudomonas and Acinetobacter, which are particularly seen in intensive care units, in patients who are ventilated, and increasingly, unfortunately, also are on general wards. When we think about sort of drug-resistant profiles, when we're talking about gram-negative bacteria, it's really the main problem is in degradation of beta-lactam antibiotics by enzymes called beta-lactamases, which have become increasingly broad in their spectrum of activity. So that where they would once only break down penicillin and not cephalosporins and not carbapenems, we now have extended spectrum beta-lactamases, which break down penicillins and cephalosporins. And we even have carbapenemases, which are beta-lactamases that break down penicillins, cephalosporins, and carbapenems as well, leaving almost nothing available to treat the patient with. And then on the gram-positive side, really MRSA is the main issue. Methicillin-resistant Staph aureus. In Enterococcus faecium, it's resistant to ampicillin, so we use vancomycin. But now there's increasing vancomycin-resistant Enterococcus faecium, which is VRE, which is again extremely serious once it takes hold. So we're going to look really at these main top 4 hospital-acquired infections, which relate to devices. But just to remember that you can have outbreaks of in hospital and nosocomial transmission of TB, of various viral illnesses, of bacteria which get into water systems like Legionnaires, Legionella pneumophilia. And then also you can have outbreaks of gastroenteritis type diseases, particularly enteritis, such as norovirus outbreaks, and even bloodborne hospital-acquired infections from needle stick injuries, which is generally, the risk is generally HIV. Most of our healthcare workers are hepatitis B virus vaccinated, and therefore that's less of a problem. But there have been cases of hospital-acquired malaria, hospital-acquired syphilis, and other bloodborne diseases. Now, the problem is that when we're thinking about the bacteria and what we're looking at and making our decisions about what causes hospital-acquired infections, we're only getting a certain amount of information. So laboratory data is generally what we use, and that gives us a spectrum of organisms and susceptibilities, but it's not the full picture. The full picture would be done by good active surveillance. And we've seen this again from, really triumphantly from Marianne and others, in terms of SARS-CoV-2, really going out to communities, looking at, we've seen surveillance of water, sewage to look for SARS-CoV-2. But what we know about hospital-acquired infections is really very limited in relation to that. It's not the full picture, but it's the picture that we have at the moment. And it's this lack of surveillance, and particularly in Africa and low middle income countries, which really hampers our understanding. But we do know certain sort of generalized facts. We know that in low middle income countries, you're much more likely to get, almost twice as likely to get a hospital-acquired infection than if you're in a high income country. We know that there are very few studies in Africa. In fact, in one of the, the Cochrane reviews, I think it was, there were only 2 out of 19 studies of high enough quality to really make any headroads into understanding it. We know that the incidence in ICUs is very high, triple that of the hospital-acquired infections, triple that of the US, again showing how much higher in low middle income countries these infections are. And in our own backyard in South Africa, 1 in 7 patients, that's a big amount, a large amount of infection, a really high prevalence, and obviously higher prevalence in ICUs because they're sicker patients with more devices and more likely to get hospital-acquired infections. What we do have is national level surveillance data of various bug-drug combinations, particularly Klebsiella and Staph aureus, Pseudomonas, and the ones I've listed. And you can go to the NICD website and register, and you can get these heat maps on a national level, a regional level, and as I'll come on to at facility level. A couple of years ago, we published this report. It's just a sort of high-level overview of what a problem we've got. When 1 out of 12 bloodstream infections with Klebsiella resistant to carbapenems, that's worrying. Carbapenems are almost your last resort antibiotic. It only leaves colistin, a terrible drug, which was kicked out in the 1960s and now has come back into vogue because we've got nothing left. 28%, now down to 24%, 23% of all Staph aureus bacteremias in South Africa are MRSA. Now, when you're using that much vancomycin, again, a very difficult drug to use, a toxic drug, one that needs therapeutic drug monitoring to be safe, not easy. And then, as you can read through here, a lot of highly resistant gram-positive and gram-negative pathogens. Globally, we report data, as do increasing number of countries, to the World Health Organization database, which is the GLASS system, the Global Antimicrobial Resistance Surveillance System. And it's a set of 9 bugs with drug combinations. And over the years, on the left, you'll see in purple the countries reporting in 2017, and now much healthier. But again, this data is only half the picture, not even half. It's only what's acquired, and it really is very much skewed towards hospital rather than community resistance profiles. And what we really need is this facility level surveillance, in fact, ward civility level surveillance. And this is available at a facility level in different hospitals in different provinces. And this, for example, is our Klebsiella pneumonia quinolone resistance rates, susceptibility of 72% in, this was in 2017, I think. So a third of all our Klebsiellas were resistant to the first line quinolone antibiotics. So you can go down, you can drill down to facility level. So we're going to concentrate now on describing and understanding the extent of the problem and how we can mitigate the sort of big 4 hospital-acquired infections. And again, as you can see, it's mainly device-related. So we're really talking about central line associated bloodstream infections. And I'm going to add in there peripheral line bloodstream infections, because it's not just central lines that get infected and cause bacteria to gain entry into the bloodstream. It's also from drips that we put up in patients' arms, generally to give fluids, antibiotics, and other things that are poorly cared for. It's also when you put anything into, as I said, into a sterile, usually sterile area, and allow a passage to the outside, you are increasing the risk of a bacterial infection. So catheter, urinary catheter associated infection is the second of the big 4. Thirdly, which we're going to start off with looking, is when you breach the skin and cut into, do an operation, you're at risk of a surgical site infection. And then when you're intubating a patient, you've got a direct access into the lungs, and you bypass the mucociliary escalator and other normal defense mechanisms, and increase the likelihood of a ventilator-associated pneumonia.
Mark,
Yep.
may we interrupt you quickly?
You may.
Can you go back 2 slides, please? One, when you say 73% of the, I guess those are cases?
No, they're blood cultures. I should have, So generally, because, we generally look at surveillance and resistance levels currently in blood, because it's it's meant to be sterile, and blood cultures, apart from if it grows coagulase negative Staphylococcus or Corynebacterium or other normal skin commensals, if it's growing Klebsiellas or Pseudomonas or others, it's significant. There are problems with surveying urinary tract infections, because often the pathogens can be asymptomatic, can be there without infection. So we're generally talking about, in this facility at Goedeskeer, our bloodstream infections for 2017 or 18 relating to the resistance and susceptibility.
What happens is somebody going around taking random blood samples and then whatever grows out of them?
No, it's all comers, all blood cultures from the facility or done at the facility. So no, it's not. But what we're trying to do now with Marianne and Andrew and others at at the Western Cape Provincial Department, using the sort of data centers to try and understand a lot better how, everything marries up with clinical diagnosis, pharmacy, records, surveillance of laboratory cases. So no, this is all comers.
Okay, so I'm not quite getting the idea here. So blood cultures are done routinely. I'm trying to figure out how is across an infection in blood.
Okay, so people have blood cultures when there's blood cultures indicated. So generally, it's a patient that comes in with a clinical illness that is indicative of infection. They have one or more blood cultures, and it's those. These are not surveillance blood cultures. These are, it's facility level surveillance data. The power of this is it allows us to understand a little bit about what our empiric hospital-acquired infection regimen should be. Because if I know, and we'll come to this, but if I know that 99 of our gram-negative bacteremias, bloodstream infections at hood of skier, 30% are resistant to the quinolones. I'm not going to use a quinolone as a first line. And so that's where it really helps at this stage. Obviously it helps on an individual level when you know the result, because you can direct therapy and steward the antibiotics.
But does the patient come in with an infection, or is this specific? Because you speak about hospital. Yeah,
this is all comers. This doesn't differentiate between community and hospital acquired.
Okay, got it now.
Yeah, so it's a very imperfect system, but it's what we've got.
And then just on the next slide, you said this first one is, I don't know what main line means as opposed to.
So this is a catheter, a central line associated bloodstream infection.
Line.
So this is this line is going into what we call a central vessel. So it goes into the subclavian vein, which is a very large vessel, which allows large volume and also direct access into the bloodstream. Very.
As opposed to a drip, which is going into an arm or something like that.
A drip is going into a peripheral vessel, a smaller vessel, and you can, if these are well looked after, these central lines can be left in for longer. And as you can see, there are multiple ports, and you can, so these are generally for sicker patients, ICU patients, transplant, chemotherapy, and others.
Thank you.
Okay, no problem. So venous catheter associated infections, be they central or peripheral, urinary catheter associated infections, surgical site, and ventilators. So surgical site infections really are much more common in low middle income countries. There are many reasons for that. And what they usually present with, as shown here, is redness around the wound. When we think about infection, the old rubor, calor, dolor, which is redness, warmth, and swelling. And then that can be only a superficial skin infection. There can be infection in the deeper skin areas, in the dermis, and then in the muscle and fascial areas. Or there can be deep-seated infection all the way down to, if it's in the abdomen, into an organ, or into the peritoneum, or wherever it is, into structures that are deep. So when you're looking at the impact of surgical site infection, basically, if you're infected in hospital with a surgical site, all your outcomes are worse and the costs are much greater. And that's, I think that's probably obvious for the reasoning. When you have infection, and particularly if it's severe and becomes a bloodstream infection, your mortality increases markedly. There's an increased requirement for more intensive care, and you're more likely to need readmission, potentially further surgery. It increases your length of stay because of the needing to treat the infection and the cost to healthcare. And this was obviously an American study. So the risk factors for surgical site infection, again, a lot of the risk factors that we talked about before in terms of the patient, immunosuppression, and that includes diabetes is an immune suppressing illness. Various other body habitus and age-related issues are are risk factors. And then there are risk factors within the operation itself. And we'll come on to some of the more important ones now. So just as an aside, which I always find quite interesting, the actual behaviors in the operating room itself can impact on the rates of hospital-acquired infections. And just to highlight to you, so every time you open the doors in an operating theatre, you're changing airflows and potentially allowing dust particles with pathogens in. And just to show in this study, if you look on the far left, the number of door openings per procedure, and this is in orthopedics, cardiac, general surgery, 50 times, 100 times, even up to, a maximum of 300 times the door opening. And the frequency of door opening per hour up to 100 times in orthopedics, and the number of people in the theatres per procedure very high. So, the first thing you need to do if you've got a high surgical site infection rate is have a look what the hell you're doing in theatre. The second thing is, which is always interesting, is that the more noise in the theatre, the more distracted people are probably, and the more, hospital-acquired infections and surgical site infections occur. In this study, again, the noise level. Now, when I was a medical student, before I was a medical student, I was invited to come because I knew somebody, an operating theatre technician, and he allowed me to come and watch. And I remember it was a cardiac bypass, and they were playing Serge Gainsborough and Jane Birkin's classic Je t'aime, which was quite a risky song at the time. Lots of heavy breathing, but lots of noise, and it's always sort of stayed with me. But now, they're different songs, but less noise, the better. So the more decibels, the higher the infection rate. And then what you do, of course, there's no dancing around. These are the particle rates generated. So we like our surgeons to stay quite still. Okay, the important thing is that these hospital-acquired infections are preventable. And it's estimated that 40 to 60%, almost half of surgical site infections, are actually preventable. And the WHO, and these references are very useful, recently have updated their evidence base globally for surgical site infection prevention. And there are a few things that stand out. One of them, we've talked about Staph aureus infections, and there is evidence that Staph aureus eradication, particularly in certain types of surgery, such as cardiothoracic and orthopedic surgery, is recommended. And a meta-analysis, as shown here, in 2015, mupirocin, both mupirocin and chlorhexidine, both chlorhexidine is an antiseptic mainly, mupirocin an antibiotic, reducing Staph aureus rates, infection rates, both MSSA, which is methicillin-sensitive staphs, and MRSA. So that does seem to be something that benefits. The other very interesting finding, which has been known for quite a long time now, is that when you are operating, you shouldn't shave the patient. If you think about shaving, it causes micro abrasions, cuts, and increases translocation of bacteria through the skin. And you can see in this quite interesting sort of meta-analysis, which gives relative risks for shaving versus chemical hair removal versus clipping versus no hair removal, and the size of the circle is basically the highest the risk. Shaving is undoubtedly the highest risk. So generally now, either clipping, use of clippers, or no hair removal is practiced. When we do go for operations, particularly non-clean operations, so in other words, operations that are going to open any body cavity or that are high risk for infection, we give an antibiotic prior to the incision to reduce surgical site infection. And when we're thinking about the bugs that cause surgical site infections, we're really talking about standard sensitive gram-positive bacteria like Staphylococcus and Streptococci. And so we need a very narrow spectrum antibiotic. And generally we use the drug cefazolin, which is a second generation cephalosporin, and we dose it by weight. Those who are obese, above body mass index and above a weight of 120 need a higher dose. And in certain types of operations, we may need to use a different antibiotic, but 99% of antibiotics used for surgical site prophylaxis is cefazolin. The timing of the cefazolin is important. If you give it too early, the levels drop at the site of the incision. And if you give it too late, the levels don't get up high enough. And it's been shown that between 30 minutes pre-incision is the ultimate, the optimal time in standard operations. That may vary slightly in cesarean section, but this is really for most operations. For some specific types of surgery, there are different routes of administration rather than intravenous, particularly for local infections, such as to prevent local infections in such as cataract, surgery, joint replacements, and other specifics. But in general, just need to know that cefazolin for most surgical operations, non-clean operations, is important. One thing that does occur, which is a problem in terms of generating antibiotic resistance, and it's an important stewardship principle, is unfortunately surgeons like to continue their prophylaxis for too long. All the studies show that actually you just need a single dose. The only time you need to repeat the dose in general is if there is a massive blood loss greater than 1.5 liters. And again, this talks to reducing the amount of antibiotic in circulation, or the operation goes on for a prolonged period of more than 4 hours. And again, it talks to the amount of antibiotic around. So in those cases, we would repeat the dose, otherwise we don't. And really, the problem is that many surgeons will continue for 24, 48, 72 hours, and some surgeons even sadly give patients antibiotics to go home with. In single, this really talks to what I've said, and in very rare cases like an arthroplasty, you may need to give a second dose. The other factors that have been found to be important, particularly in cardiac surgery, is body temperature control and diabetic control. And again, that talks to the immune system optimizing, particularly in diabetes. If you've got poor diabetic control, your white cells don't opsonize and function as phagocytes so well. And it's important that you can maintain good body temperature and diabetic control. So all in all, for each of these hospital-acquired infections, there are simple bundles of care which really look to what are the 4 or so essential features or interventions that will reduce that infection. And for surgical site infection, the 4 that we concentrate on is appropriate hair removal, the appropriate use of antibiotic, good glucose control, and normothermia, which is really what I've gone through. So this bundle, if you just concentrate on this site infection.
Mark, why is it bad for people to be sent home with antibiotics or prolonged antibiotics?
Because you're exposing, firstly, any antibiotic that is given unnecessarily is bad, and we'll come on to the reason why when we talk about antibiotic resistance. So it engenders antibiotic resistance, and it basically also affects your microbial flora and puts you at risk of collateral damage from Clostridium difficile and other things, but we'll come on to that.
Thanks.
Okay. There have been a number of studies looking at these sort of bundles. This one was very successful for the neck care hospitals, Adrian and colleagues, showing that if you implement a bundle to reduce surgical site infection, you do indeed reduce the rate. And now we're going to move on to the second type, these venous catheter-associated infections, bloodstream infections, so-called CLABSI or PLABSI. Again, there are significant interventions that can reduce the risk, and they basically come down to not putting one in if you don't need it, getting it out as quickly as you don't need it, and taking care of it when it's in. We have checklists, and we know that checklists, particularly in ICUs, work. When we're putting them in, we go through, it's usually in the ICU, you know, the person putting them in will have a buddy there who ticks off everything, makes sure that they're put in correctly under aseptic technique. And then afterwards, each day, a bundle is performed and tick sheets are used to reduce the likelihood of infection. The peripheral lines are a particular problem. This is just a smattering of what may be found on a ward at a single moment in time. I think this was from one ward in medicine at Horace Skier. Whenever you have poorly looked after lines, you're allowing, remember these catheters, these are plastic catheters going directly into breaching the skin. So when they're not secured properly or when they're badly looked after, you're increasing bacteria into the skin. In the bottom right, you can see that this one's already showing redness around the proximal part of the vein that the catheter is going into. There's already a surgical site infection there. We did a study here, Sean led it, but Nicholas Steinhaus was the first author. We looked at our first 100 Staphylococcus aureus bacteremias, which is really a marker of poor peripheral and central line control in adult patients as defined by over 13 years of age. And over half of those were due to a peripheral line infection. And look at this inpatient mortality, close to half, 41% death from Staph aureus bacteremia, with a 90-day mortality, again, around 47%. So this is high mortality, even higher than high-income country. And MSSA bacteremia, staphylococcal bacteremia, really is one of the most horrific things in this hospital and in most hospitals in South Africa, unfortunately. High mortality and actually preventable. The third of the big four is catheter-associated urinary infections. Again, when you've got an abnormal collection between the sterile environment and the outside, you're at risk of bacterial infection. So preventing this is avoiding the need for catheters. The only three real reasons that you need a urinary catheter is one, if there's an obstruction to urine outflow. So in men, it's usually prostate enlargement, or in diabetes, sometimes you can get what we call a neuropathic bladder, so muscles don't work properly, and so urine can't get out. So in that situation, you may need a urinary catheter. If somebody comes in critically ill, their fluid balance is important. The first 24 hours, they may have urinary catheter to define their requirements. And then the third is if you've got somebody who's got severe bed sores and incontinence. Otherwise, there's no real reason for a urinary catheter. Unfortunately, historically, urinary catheters have been put in for everything from nurses, just being too short on the ground and therefore not being able to get patients to the toilet, to just idiots putting them in for no good reason. When you're putting it in, again, you have to put it in under special aseptic technique. You need to monitor them and deal with them correctly, and you need to get them out as quickly as possible. In this study, in our setting, half of catheters in place when unnecessary. So the prevention bundle, again, avoiding them, aseptic technique and putting them in, maintaining the catheter carefully and making sure it's clean. Often we see urinary catheter bags lying on the floor. The minute you get a bacteria through, it can ascend up through the bag, through the urinary catheter and into the bladder, and then get it out as quick as possible. Lastly, ventilator. Yeah.
Sorry. I often wonder about people with colostomy bags or people with those urinary bags. Instead of that, so they don't have the urethra doesn't work anymore. So they have I don't know if it's still called the colostomy bag. And they're kind of going home and sticking these things on and off. And I'm always amazed that they don't get infected. How's that? How do you manage that? Which is not quite a real infection, right?
No, I mean, so there's two. I think we just need to define what we're talking about, because others on the call may not realize. So, I mean, a colostomy bag is obviously a colostomy is an opening that has been fashioned between the colon. Usually, can be you can have an ileostomy as well, or from the small bowel, but a colon out onto the skin surface because there's a blockage going into the normal gut. In that situation, remember the gut is a non-sterile area, and generally they don't get infections. Occasionally, in urinary pathology, you may have to divert the outflow of a urinary tract into onto the outside, which goes then into a bag, and that's almost like an external bladder, as it were. And that can become infected, but you teach the patient to how to deal with that and how to do it as aseptic a technique as possible.
Okay, thank you.
Okay. So ventilator-associated pneumonia occurs. It's a pneumonic illness, an infection of the lung parenchyma, the lung tissue, in somebody who is being ventilated and is intubated, either through a tracheostomy, either through an endotracheal tube, which goes through the mouth into the trachea, or coming out of the trachea. In patients in the long term may need to prolonged ventilation through a tracheostomy. And as I've said, it usually will occur within or after 48 hours after removing the device in this situation. Ventilator-associated pneumonia is quite common. It occurs in almost a fifth of patients who are ventilated, and it does increase length of stay in both ICU and overall in hospital. And obviously there's costs to life as well as hospital costs. And again, there are sort of 4 things that have been shown to reduce ventilator-associated pneumonia: reduction in aspiration and the ability to the lung immunity and immune mechanisms and clearance mechanisms to work optimally. So we nurse the patient at about 45 degrees. The sedation is an issue. If you over-sedate the patients, there's an issue with the intubation time. We know that if you reduce peptic ulcer disease, interestingly, by prophylaxis, it reduces VAP, and then also DVD prophylaxis. So these all reduce the likelihood of a ventilator-associated pneumonia. What's very useful is a visualization of your progress in terms of hospital-acquired infections. This is a Welsh cross. As you can see, it's based on a calendar, and on a daily basis, you can fill it in so that people in real time can see how they're doing in their interventions. So once you put in a bundle, maybe you're going to do this Welsh cross for a month or 2 beforehand, put in your intervention and see how it goes. And it's really important to give feedback, and visual feedback's very powerful. So I'm going to pause just here for a second because I'm going to move on to the antibiotic resistance side of the talk, and just ask if there are any burning questions. I mean, we can have a full discussion at the end. There's about another 20 minutes or so of slides, but if there are any other burning questions around hospital-acquired infections, I'm happy to take them now. But if not, I'm going to go on and just highlight to you that when we talk about drug resistance in general, there are a number of different definitions, and the standard definitions, I mean, everybody will be very au fait with the terms MDR and XDR in terms of TB. It has a very specific meaning, MDR being resistance to the first line of rifampicin and isoniazid, XDR being resistant, is MDR plus resistance to either the quinolones or the injectables. And some of that's going by the by now, obviously because of the new treatment regimens. And in, the same applies for bacterial infection. When we talk about multi-drug resistance, Here we're talking about a reduction in your availability of antibiotic classes. Remember, there are a number of antibiotic classes we use, the beta-lactams, like penicillins and cephalosporins and carbapenems. There are minor glycosides, amikacin, gentamicin, streptomycin, very occasionally. There are quinolones, and there are different glycopeptides and others. Anyway, so MDR is non-susceptibility to more, greater or equal to 1 agent in more than 3 antibiotic classes, so your choices are down. Even more so, XDR, you've only got 2 classes of antibiotics left. And now obviously there's pan resistance where there's nothing left, but there's also now this category called difficult to treat resistance, which was first really defined in the USA. And it really talks to basically losing all first-line antibiotics. So it's treatment limiting resistance to all first-line antibiotics. And in general, those are beta-lactams and the quinolones. And in the beta-lactams, it includes those beta-lactams that are paired with enzyme inhibitors, which reduce the action of enzymes that break down the beta-lactams, which again, I can go into later for you. So just so, because if you do read anything now, this term of difficult to treat resistance is increasing. And it really highlights the main problem of antimicrobial resistance. Now, really over the last century, we've seen a miracle option that we have in antibiotics dissipating. And this is an interesting slide to me because it really shows a progression, and at the end of the talk I'll come back to it, because 20 years before 20 plus years before Fleming even discovered penicillin, there was this newspaper cutting from excuse the pun, from the US, where a YMCA groundsman was cutting the grass in bare feet and cut his foot with a blade of grass. It became infected, and of course that was before antibiotics, and the only way to control the infection was to amputate his foot. Then in 1942, a policeman was the first, in fact, to get penicillin. Florian Chain in Oxford had produced it, and I think his name was Arthur Adams. Harold Adams. I can't remember his name, but he was a policeman. He had sepsis, he had an infection of the face, and I think he'd got a rose thorn infection. And he was treated, and he started to make a miraculous recovery. Remember, people generally didn't recover before that. Unfortunately, I think day 2 or 3, they ran out of penicillin, so they took his urine and rushed it over to the laboratory across the way in Oxford. It was at the John Radcliffe, and Florian Chain were working the other side, and they concentrated up the penicillin, gave him again, seemed to improve, and then unfortunately it just ran out completely and he died. But thereafter, penicillin became available, and this middle image is of a child who would have died prior to penicillin. Now, in the last 10 years, we've really seen the rise of resistance in bacteria, which is changing modern medicine and increasing morbidity and mortality. And to me, in fact, after many years now of considering antimicrobial and antibiotic resistance, to me, COVID has really highlighted the fact that antibiotic resistance in particular is actually another ecological disaster of our own making. We as we encroach on environments, we increase zoonoses. We've seen that, I think, almost definitely. We certainly saw it in SARS. I think we've seen it with SARS-CoV-2. I believe it did come from bats. We've deforestation, changes of habitats, increasing the interplay between species, and then finally zoonotic infections from animals to human. This poor old koala had its habitat decimated. And antibiotic resistance is also an ecological disaster because we are symbionts. There are more, as you know, I think more bacteria in and on our body than we have human cells. And we have a whole microbial populations not just bacteria, but fungi and viruses and archaea, protozoa that make up our guts, our skin, in fact, almost every surface and organs that you wouldn't even expect. Even the placenta has a microbiota. And it's been understood now that these bacteria have critical roles, particularly in our systemic immunity. Once you start playing around with our gut microbial flora, particularly, you alter systemic immunity outside of the gut, including in the lung and elsewhere. There have been some amazing animal studies. It also obviously aids in digestion. We don't have cellulase. It's important in our digestion of plant materials. And they outcompete these bacteria in our gut, particularly, and in our other surfaces, outcompete pathogenic bacteria from gaining hold. And that's particularly important when we think about Clostridium difficile. What's also interesting is that there's now an amazing degree of research on wide-ranging research on different syndromes, different diseases, from obesity, metabolic diseases, neuropsychiatric diseases, skin diseases, all associated with abnormalities of microbial makeup of these areas, and also gene expression. When you read about microbiota, that's the composition of the flora. So that's what makes up the bacterial, fungal, viral populations. And the microbiome technically is the gene pool that those bacteria have and express. So we're unable to live in symbiosis. We have been decimating our bodies with unnecessary antibiotics. Everything that happens in humans happens in animals and in the environment. If you plug in antibiotics into the environment unnecessarily, bacteria in the environment become resistant. Well, why is this? The other thing is just to mention that this is not a war against drug-resistant bacteria. This is a war against humans. It's us that is doing this, not the bacteria. And this is what I mean about living in symbiosis. If anybody thinks this is a war against drug-resistant bacteria, you're fooling yourselves. It's a war against the idiocity of human beings, unfortunately. So why does this happen? So it's about natural selection. Here in this graphic, you see a population of bacteria, say Staphylococcus, it doesn't really matter what it is. And by natural selection, one or more of them will have a mechanism which allows them to be resistant. And that can be anything from reducing the ability of an antibiotic to get into the bug. Antibiotics that do get in can be efflux pumped out. You can have enzymes in the bacteria which will degrade the antibiotic, or the bacteria can change the site of binding of the antibiotic and not allow it to work. So there are multiple different resistance mechanisms. And remember, antibiotics come from nature. They come from bacteria and fungi in soil and other environments, which job it is to protect those bacteria. But also, in fact, it's quite complex, involved in quorum sensing and other things. But some will have a resistance mechanism. And if you give an antibiotic, you'll wipe out the sensitive bacteria and you'll leave the resistant bacteria. Given the right circumstances, those bacteria, drug resistant, will replicate and become the predominant bacteria. Now, if that happens, they can either cause an infection in the body. If an infection is going to occur, it will be more likely to be a drug-resistant infection. Or if they're on the skin, they can be transferred to others and cause infection in them. The broader the spectrum antibiotic, we talk about narrow spectrum and broad spectrum antibiotics. Narrow spectrum just really only target a few type of bacteria. Broad spectrum antibiotics will have a broad spectrum. And so if this occurs, if you think about a population of bacteria with different types of bacteria, the light colors being the sensitive and the darker, if you have a broad spectrum bacteria antibiotic, you may select out a number of different drug-resistant bacteria. And again, often one will take precedence over the other in their ability to colonize and cause disease. But the broader spectrum antibiotic, the worse the outcome. So antibiotic resistance is intimately related to the amount of antibiotic that's used. And this is beautifully shown in high-income countries where penicillin-susceptible Streptococcus pneumonia is charted against the use of penicillins in the outpatient. You can see the higher the amount of use of penicillin in the outpatient, the greater the amount of resistance to penicillin, in this case in Streptococcus pneumonia. And this occurs for any antibiotic and bacteria combination. Interestingly, in low middle income countries, there's a suggestion that this direct relationship is no longer that important. And when this is a good article, I would really suggest this article in Lancet Planetary Health. You'll get these slides so you can get the references. Well, what was found is that actually in this situation, they looked at a whole series of different factors, risk factors for resistance. And actually it's your infrastructure index. So the bang for buck in preventing antibiotic resistance in low income, low resource centers is actually probably infection prevention. It's access to clean water and sanitation. And so that tends to trump on a population level antibiotic use. Not to say on an individual level that antibiotic use still doesn't drive resistance, but there does seem to be a difference between high-income countries that obviously went through industrial revolution, have good water and sanitation, etc., that plays a role. We're also seeing that over the last 10, 15 years, that the low middle income countries, antibiotic use is increasing at a dramatic rate towards that's used in high income countries. And it does relate to wealth of the country. In Africa, what we're seeing, in particular in low middle income countries, we're seeing the migration from the rural environments into urban settings. And we're seeing many, many more cities with populations of over 1 million, particularly in Africa. And when that happens, you increase antibiotic use. Now, partly that's a good thing because there may be an increase in access to antibiotic for those that need it. And that would be great if people only got antibiotics when they needed them. But unfortunately, as you know, most people get antibiotics when they don't need them. The urbanization and crowding increases the transfer of infection, potentially bacteria infections. Pollution increases respiratory diseases, gets people to doctors more, and even indoor cooking and other pollution, indoor pollution in certain communities will again increase respiratory illnesses and increase, we know that respiratory illnesses and presentations to doctors and clinics is a very key driver in community antibiotic misuse. So the consequences of urbanization in low middle income countries is to increase antibiotic use. Unfortunately, in the community, again, as I've said, the predominant inappropriate use of antibiotic rests with people presenting with cough and mild influenza-like illnesses, viral infections caused by a whole slew of respiratory viruses. And they don't need an antibiotic, they need symptomatic treatment. We've seen this with COVID. Unfortunately, COVID has magnified the problem, again, a viral infection, which we very, very quickly realized did not require antibiotics. If you look at the systematic reviews, meta-analysis, the pool prevalence of bacterial co-infection with COVID patients admitted to hospitals is 7%. Yet in most of the databases, over 85% of people get an antibiotic and often a course. So you've got a massive increase in the number of people getting inappropriate antibiotics, which drives antibiotic resistance. Unfortunately, it's not just the community. This is an appalling study, thankfully from about a decade ago. Let's hope it's improved. But this was a study that a point prevalence survey took every single ICU patient in South Africa, private and public, child and adult, and went round and took every 8th bed and took information, took the data on how many antibiotics and what for they were being used. Now, thankfully, most people were on 1 or 2 antibiotics at the time, both in private and public. But look at the right-hand side. There were people in hospital in South Africa in an ICU setting that were on 10 antibiotics or antimicrobials at the same time. And this is just one patient. Cloxacillin and ticaplanin doing the same thing. Metronidazole doing the same thing. as a number of the other antibiotics like meropenem and ceftazidime that have anaerobic cover, gram-negative cover from amikacin, ceftazidime, meropenem, levofloxacin. This isn't one after the other. This is the same patient, the same time. Why did this occur? Because nobody looked at the drug chart and nobody stopped an antibiotic. There's no reason for this, and no, it's pure negligence, and the doctor involved should have been struck off. Now, what you do in a human, the more antibiotic you give to a human, the more likely you are to select out antibiotic resistant bacteria in and on that human that can cause disease, infection with a drug-resistant infection, or be transferred. And every time that happens, the cycle continues. So if you've got a drug-resistant infection in a human and you need to give a much broader spectrum or higher end antibiotic, there will be bacteria that are resistant to that antibiotic, and they will be selected out, and they will then become predominant until the end game occurs where there's nothing left. What happens in humans happens in animals. And in animals, antibiotics are used for a variety of issues. In companion animals, in your pets, generally they're used in a similar way to humans. They're used to treat infections. But unfortunately, again, they're often used when there isn't an infection there. And again, your pets will have antibiotic resistant bacteria. And it's well known that MRSA can be transferred between your loving pooch or Miss Tibbles or whoever you've got at home and you. Unfortunately, antibiotics in animal health are used predominantly in food production systems. And it's been known for many decades that if you give antibiotic when the poultry or the cattle or lambs or whatever are being reared, it as animal growth promoters, they promote the growth of the animal quicker, muscle mass is increased, and they get to market sooner. So globally, until relatively recently, there has been antibiotic being fed to animals in their feed and in their water. Now, the European Union stopped this in 2006, Denmark a little bit before, but in many countries in the world, this is including South Africa, this is still occurring. Where it doesn't occur, there's an increased use of antibiotics in what is called metaphylaxis. In humans, for HIV, for example, you well know that we give cotrimoxazole, Bactrim, to people with C. diff counts under 200 to stop them getting secondary infections or other infections in the first place. The same's done in animals reared for food. Think about it. If you've got 3,000 chickens or 30,000 chickens in a shed and a couple start coughing, you're not going to go around with your stethoscope chicken to chicken and treat each one. You're going to bung in a lot of antibiotic into feed and water to try and stamp that out. And often that's used, that's called metaphylaxis, not prophylaxis. And that's often used even if there's no illness in the herd or the flock, just to reduce. Now, BRICS nations are the #1 increasing set of nations for animal protein requirement. And that talks to a change in social and economic stature. So as you go from low income to low middle income, upper middle income to high income, animal protein requirements increase and plant-based diets and crops reduce. And so the more we're going to consume, the more our populations grow, the more problem there is. And because of global climate change, the amount of agricultural land and productivity is shrinking, and therefore intensive farming increases and more antibiotics are used in food production. So how do you reduce that? You give the herds and the chickens more space. This is a plant in a factory in the Netherlands. And actually what you can see is a bit of space between the chickens. In most other farms, you'll see no space at all. And actually on the right-hand side, you can't see it very well, but there are little doors there to allow them outside. Once you de-stress the animals, they get less infections and less risk. But this is costly. Increasing biosecurity, biosafety in farms, reducing, so in other words, putting in infection prevention is a costly business, and it's cheaper to give a lot of antibiotic. And that's a problem.
Mark?
Now, it's not so much the antibiotic that's the problem to humans. It's the fact that when you give the chickens and the cattle the antibiotic, they select out antibiotic resistant bacteria in their guts. When they go to slaughter, you slaughter a chicken, take the guts out, the spillage bacteria occur, get onto the carcass. It then gets onto the meat, which then goes into the shells. If there's poor kitchen hygiene, it's transferred to humans, and so on. And we know, for example, from about 2012, 13, 14, 15, that E. coli resistant to our last resort antibiotic colistin was transferred from E. coli in poultry to humans, including in South Africa. So we know this happens. So it's not so much the antibiotic. When chickens go to slaughter, there's 2 or 3 days of what we call a washout period where they're not given any antibiotic itself. But remember also that these chickens and all these food production animals are being given antibiotics, which they then excrete into sewage, which then goes into the environment, which then causes environmental bacterial selection, etc. I will take questions at the end.
Okay.
So the FAO, the World Organization for Food, has told everybody to halt growth promotion. That's great, but as I've said, it's a problem because it's costly and it's aspirational in low-income countries. How do you reduce the need for growth promotion? You improve housing, you improve hygiene, you improve nutrition, and you improve the health of the animal, as I've shown you. Now, infection control is still a major problem, and as I said, the environment is the third part of the sort of trifecta of environmental, animal, and human health, which makes antibiotic resistance such a quintessential health issue and a real problem. And while 1 billion people are still practicing open defecation, only 20% wash their hands, not only are you going to be increasing antibiotic and antibiotic bacterial environmental problems, you're going to be increasing transmission within communities. And while communities in low and middle income countries have to drink dirty water, you're causing diarrheal illnesses, which are one of, again, including as with cough, you're causing inappropriate antibiotic use. Most diarrheal illnesses do not require antibiotics, but most get them. One of the things that's really hampered the global action against antibiotic resistance is that, unlike COVID, where the threat was felt in the here and now, the threat of antibiotic resistance and antimicrobial resistance has been highlighted as a futuristic threat. So this was work done by Jim O'Neill and the AMR review in 2014-15, really a series of papers which defined the landscape and the problem. And it showed that at that time, there were about 700,000 cases of antibiotic resistant drug infections causing deaths in the world. And by 2050, that's projected to increase to 10 million extra infections a year. Now, remember, in COVID, I'm not sure exactly where it is, but it's somewhere between 2 and 3 million in the last 18 months deaths. Now you're talking within, 29 years or so, 10 million a year if this is not mitigated. Now, that's frightening and it's impactful, but it leaves everybody cold. And you do surveys of how people react to this, they can't associate with it. Now think about the Johns Hopkins site of surveillance and the increasing deaths, vaccination rates, everything, and how real it feels in real time. This is not what's happened in AMR, and it has impacted on it by not being able to really give it a face and leaving everyone cold. But this is the projection. And, you know, the main problem is going to occur in low middle income countries in Africa and Asia. So we're projecting for just over 4 million deaths, extra deaths from drug-resistant infections. And of course, in Africa, you've got drug-resistant TB, you've got drug-resistant HIV, drug-resistant malaria. So we now, unfortunately, have artemisinin-resistant malaria in parts of Africa, which could really impact on the elimination campaign for malaria. And the announcement of a malaria vaccine is obviously an incredibly important, potential important mitigator of anti-malarial resistance risk. And it has a huge impact on global GDP. You know, you're wiping out potentially by 2050 a massive GDP. But as I said, this leaves people cold. How do you really impact? How do you make it understandable for people? And unfortunately, again, COVID has really brought that home, hasn't it? Everybody knows somebody who's died of COVID. Or people know of people who've had COVID and ended up in ICUs. And just like COVID, you know, I'm going to leave you with this slide. Well, in fact, not this slide, this is the penultimate slide. Basically, the true cost of antibiotic resistance is impacting on our health service and what we can offer. We've been through hospital-acquired infections and surgical site infections, for example. You know that now that you need an antibiotic to stop infection in that surgical site. If there was no antibiotic and you had to undergo a hip operation without an antibiotic, somewhere around half of people will get an infection, and with no antibiotic to treat, about 30% will die. Are you going to have that in operation? No, you're not. Those odds are too high. Yeah. Cancer chemotherapy causes your immune system to go, you know, become immunosuppressed, increasing bacterial infections. Transplantation, reducing rejection of an organ requires immunosuppression. Everything that you take for granted, not just treating infections themselves that occur in the community or in the hospital, are put at threat through antibiotic resistance. And that's why you need to do about it. But at the end of the day, antibiotic resistance is intensely personal, just as COVID is. So I told you about that case in 1899, before the advent of antibiotics, where the guy was cutting the lawn, got his cut in his foot, and had to have his foot amputated to save his life. Well, this was a patient, and there's a number of patients from Goedeskeer who had a prosthetic joint infection. So they'd had a knee replacement, and that replacement had become infected in time. And this is the bacteria, Acinetobacter baumannii, which is one of the escape bacteria. And this is the biogram, which shows an R, which means it's resistant to all of these antibiotics, including the last resort, which is colistin. There was nothing. There were no antibiotics to give this patient. How did we save the life? We amputated his leg. That's what antibiotic resistance means. That's what's happening now and going forward. And until these stories really get out to people and people understand the impact of a pandemic called antibiotic resistance, because it is a pandemic, just as COVID is, then we've got a problem. So it's important that you go away understanding that hospital-acquired infections and hospitals are dangerous places. We put in devices and we're doing things to patients that put them at risk. They are at risk themselves, largely because of their pre-existing conditions and the fact that they are often sick. And we need to mitigate the chance of them getting an infection by simple bundles of care. And then you need to go away understanding just how impactful antibiotic resistance is on a global scale, the fact that it is the quintessential the quintessential one health issue in public health. There are very few diseases or infections that are One Health related. This is the one, and that's why globally you need the tripartite alliance, the WHO for humans, the OIE for animal health, and the FAO for food production coming together to really do something about it. The AMR was only the fourth health topic to get a high-level meeting at the UN General Assembly. And that's how serious it is. Anyway, I apologize, I've spoken enough. I've gone over the time I wanted to spend with you. I'm sorry, it's just over the hour. I'm going to stop sharing my screen. It'd be great if you could put your cameras on so I can see people. And I'm very happy to take any questions. If you put your hand up, I'm happy to take it. I see that Neville's got his hand up first. So Neville, I'll take your question. You're on mute at the moment, Neville.
I said I'm the chatty one, I'm sorry. But I have just two follow-up questions. First of all, did I understand correctly when you said that antibiotics are used in animals on farms to promote growth? Is that what you said? Yes. How so?
They're animal growth promoters. So as I said, it's been known for many decades that if you give food production animals very low doses, subtherapeutic doses of antibiotic, it increases their muscle mass and increases or reduces the time to market. Largely, it relates probably to suppressing inflammation and infection in the gut. So it maximizes feed utilization by the animal and then muscle production.
Yeah. Oh, you just froze, Mark. Or was it me? Is Mark frozen or am I frozen?
No, he's frozen for me too.
Okay. Maybe he got load shed. No, not quite. Let's see if he comes back. He seems to have gone. It's very frightening.
Get him off with your question, Neville.
Sorry, Sarah, what were you saying?
You obviously scared him off with your question.
Yeah. It's absolutely. How many of you here are medical people? Oh, there he is. He's back.
Yeah, hi, sorry, I had to take an
Hi.
urgent call. So I saw that
sorry,
Mark dropped, but thanks, welcome back, Mark.
Sorry, I dropped. Edurom dropped. Edurom, sorry, I don't know if I answered your question fully.
No, you did, Mark.
Neville.
You did. And I had one quick follow-up, and that was, is it not envisaged that the sort of ultimate antibiotic will be invented, which is resistance proof, or is that absolute folly?
It's not absolute folly. There's nothing that's impossible. I mean, I think the issue is that, bacteria are very adaptable. They, as you know, they replicate at very, very high speed. They're far, if they have a brain, which I think they probably do, they're far cleverer than we are. And they've managed, if you look at the resistance, the acquisition of resistance by bacteria in relation to the launch of the product into use, it's really quick. Yeah. There's a new antibiotic for a relatively new. So the beta-lactam antibiotics, one of the reasons gram-negative bacteria become resistant is because they produce enzymes which break down the beta-lactam. So what people have done is they've invented a combination between the beta-lactam and adding in an enzyme inhibitor. So there are some new kids on the block that are being used in the high-income countries for untreatable infections, which now this is a new antibiotic which allows treatment. One called ceftazidime-avibactam, for example. In South Africa, that's only been used in a handful of patients in the private sector, but already the resistance rate is 13 to 16%. And so, these become resistant incredibly quickly. They're also incredibly expensive. I didn't talk about access, but access to antibiotics, and particularly the new antibiotics, is really problematic. And it's not just the new ones, it's the old one too. But ceftazidime-avibactam is 84,000 Rand a course. Cefidoracol, another new antibiotic, acidrophil cephalosporin, is 110,000 Rand for a 7-day course. Now, we couldn't use during COVID, we weren't allowed to use tocilizumab, an IL-6 inhibitor, because it was 7,000 Rand. Okay. Now think about trying to use 110,000 Rand course for a single patient. So access is a problem. The other reason access is a problem, just for interest, because it is interesting, is that old antibiotics aren't sexy because they don't cost. And there's very few producers, and there are very few producers of the active pharmaceutical ingredient. In fact, one antibiotic called piperacin-tazobactam is a very important antibiotic to us, and there's a single factory in the world that was producing the active ingredient, and it burnt down. So for almost a year, we had no piperacin-tazobactam, which is a disaster. Yeah. So when you can't get hold of antibiotics, that's the other issue. That's the other side of the coin. A lot of people are dying in low-middle-income countries because of lack of access. But we also know that from COVID, don't we? Because lack of access to a number of the drugs, the number of the monoclonal antibodies, and number of the vaccines for a long time, and so on. Anyway, sorry, I'll shut up now. Who else? Anybody else for a question? Stunned you all into silence. Fantastic. Or you've frozen again. Gail.
Hi, thanks very much for the talk, Prof. I wanted to ask, it seems that developing more antimicrobials is not the answer, and simple antibiotic stewardship doesn't seem to be working very well. What are the next steps in terms of tackling antimicrobial resistance?
Yeah, it's a great question. So look, it's not a single intervention, Gail. It's, everything has its place. And some things have their place more in different settings. I showed you those graphs of high-income country versus a low-middle-income country settings where that relationship between antibiotic consumption and resistance wasn't quite the same, was it? So it suggests that maybe your bang for your buck in low-middle-income countries is in provision of safe water and clean water and safe sanitation, for example, and other infrastructure issues. So that plays a role. Antibiotic stewardship does play a role. There are a number of studies, and there's a very nice meta-analysis, systematic review. I think the sort of senior author was Evelina Tacconelli, which proved that antibiotic stewardship in hospitals reduced antibiotic resistance rates, and particularly when you added in an intervention to improve hand hygiene. So, on a global scale, stewardship is important. Access R&D for new antibiotics is absolutely essential, and there's been a massive amount of money put in to the development of new antibiotics, and there's a pipeline now which had desiccated. In 2011, there was nothing. There's a group called CarbX that is the sort of pipeline, the early pipeline developer, which has a number of, is funded, I think, by BARDA and the Wellcome Trust, and is run out of Boston. And they have multiple different candidate antibiotics in phase 1. and 2 trials. And then there's GARD-P, which is a Global Antibiotic Resistance Research and Development Partnership, which is a sort of implementation and phase 3, phase 4 studies arm. So that plays a role. And then trying to increase awareness and education, and that also plays a role. So it's also getting a civil society on board. And when I say civil society, I don't mean general civil society that currently exists, which is really mainly intent on supporting governments in their national action plans for antibiotic resistance and interventions. I'm talking about a civil society of people affected and stakeholders like Treatment Action Campaign or others who really are invested in this, and it only builds out of more and more people unfortunately becoming affected by it, by which time, sadly, of course, it's probably going to be too late. But I think it's a jigsaw. It's not a single issue, and everything plays its role.
Thank you.
Okie dokie.
Thanks, Mark. I don't see any other hands. So
Can I ask
think
one question, actually?
Sure, with pleasure.
Can I have just for hands up on the screen? Who has been scared by this into action by this talk? Anybody? Okay, good, excellent. I don't mean to scare you, but I hope I've at least shown you that there are problems. And when you or your loved ones go into hospitals, make sure that people wash their hands and make sure that people don't touch you without being necessary. And, I don't want to scare you out of, if you're going in for an operation, good luck and everything will be fine, obviously. But, just be mindful that this is a problem.
I'm assuming the remaining hands up are because you've been scared and not for questions.
Well, not me. I always have a question.
Neville always has a question. We can rely on you.
Which is a bad thing. I just want to ask you about what are the things that people take for their gut flora? What's it called?
Probiotics.
Probiotics, of course, yes. So there's all these schools, people that swear by them. We're talking about the sort of natural ecology of the human body, and I've read this incredible book on the human body by, damn it, came out at the beginning of this year. The very famous author that does all these big, he spoke a lot about the microbial community on humans and indicated that everyone has a completely different set of organisms, of bacteria. In other words, they're almost individual specific. But my question is, so we're taking antibiotics for whatever infection we might have, and we are doing this damage, as you indicated, to our own natural flora. Do probiotics really work? I mean, are they something that is it really useful as either a prophylaxis, as kind of general treatment, or something to take after treatment with antibiotics?
Yeah, so look, I mean, the first thing is try and do no harm. So healthy diet, not taking an antibiotic when you don't need one. If you need an antibiotic, of course you take it, it's life-saving. But, trying to just in general health and obviously pre-existing conditions, diabetes, obesity, all these things actually play into your microbial flora. When you say individual, yes, we are all different, of course, but actually when if you took all of our gut microbiota, the actual sort of classes of bacteria and fungi and things are going to be similar unless you've got something else or you have taken antibiotic or whatever. The basic answer to your question, there's been a lot of studies on probiotics and relatively few have shown actual benefit. There is some evidence that probiotics at the same time as taking an antibiotic in a certain patient groups, particularly the elderly and those potentially with illnesses, particularly critical illness, potentially going on to critical illness, may reduce antibiotic resistant infections, improve outcome. And some people swear on the use of probiotics, and particularly in the UK, a lot of GPs, and here a lot of GPs will give you a probiotic at the same time as an antibiotic. Partly, of course, not all the other thing to say is just not all probiotics are made equal. You can get probiotics which are Saccharomyces, which is basically yeasts. You can get probiotics which are lactobacilli, which is the main one. And you can get probiotics which have a bit of everything. Whether it really makes a difference, I think generally it doesn't. I don't think that being unhealthy in some ways and taking a probiotic is going to counteract that. So generally, I think, the jury's still out largely about probiotics, and they only really have been shown evidence-based to be of benefit in certain patient groups. So I would err on the side of eating healthily, trying to optimize weight, optimize the control of any pre-existing conditions, and not taking an antibiotic if you've got a common cold.
Thank you.
Thanks, Mark. That sounds like a great note to end on. It sounds like some very good common sense, apart from anything else. And just to comment on being scared, I've taught this course for many years, and the thing that always scared me was an airborne or droplet-borne respiratory virus that would become epidemic. And I thought I'd never live to see the day when it happened. And here we are. And I think this is a much more real threat than SARS-CoV-2. So thanks very much, Mark, for, I think, not so much for scaring us, but for making us all aware of the important issue and ways to address this. And once again, just an awesome overview of both hospital-acquired infections and antibiotic resistance. Many thanks, and thanks to all of you for joining us.
Pleasure. Thanks for the opportunity, Marianne. Take care.
Cheers. Thank you.
Nobody should be scared. All will be well.
I've heard that.
If Gail
before.
is smiling like that, how can anything be bad? Okay. Neville, you need to smile more in your picture. Cheers. Bye.
Cheers. Thank you. Bye.
Bye.